Hello, I'm Dr. Brian Cole, and I'd like to present the biologic augmentation for rotator cuff repair and what really works. My disclosures are on the AAOS website. We know that rotator cuff tears are an attritional disease and is one of the most common causes of shoulder pain in individuals over the age of 50. There are millions of rotator cuff tears present in the United States, for example, in individuals over the age of 65, yet we only repair approximately 500,000 per year. And that's largely because it's a condition that is where patients are largely adapted. They have secondary mechanisms that essentially can prevent them from presenting with clinical conditions of pain and loss of function. But when they do require repair, the clinical outcomes are quite favorable. But unfortunately, failure of structural integrity is quite common. When you ask patients what they're looking for with rotator cuff repair, they are typically looking for less pain and more function. But what's interesting in some of our work, we've demonstrated that they would even accept some level of pain as long as function returns. Unfortunately, given the fact that it is an attritional disease, there are a number of biologic challenges, as you see here, and we either see a failure to heal or re-tears, and it's largely due to deteriorating biology over time. In general, what we're looking for is enthesis regeneration, but we often get is reactive scar and a failure of mineralized fibrocartilage repair at the level of the enthesis. And this likely happens due to inflammation and fibrosis rather than true tissue regeneration at the enthesis. And what's interesting is we spent quite a bit of time trying to determine what are the best biomechanical constructs, and yet we still see failure rates that are somewhere in the neighborhood of 20 to 94%. And what's fascinating is most of these occur in the first 6 months. And then what's often asked is, look, if there is a re-tear, does it matter clinically? And what we have found is that patients with healed rotator cuff tears often have the greatest strength and the best satisfaction compared to those with an unhealed rotator cuff. One of the challenges is that our outcomes systems that we currently utilize don't always engage the constant score or other measures of functional impairment that could otherwise skew a score related to satisfaction. But in general, patients are typically more satisfied when the rotator cuff is healed. There are several research reports that have looked at patients who undergo rotator cuff repair and have looked at independent variables they may predict who could fail. And I would say that probably the most common variables are individuals with age greater than 70, large tear size, a high degree of retraction, when there's infraspinous involvement, bone mineral density relates exactly to the biology at the enthesis, and then level of activity. This study by Ju-Han Ho and Jun Kwan and co-authors looked at 603 patients. This is a level 3 study from a single investigator, but what it showed is that when these essentially the points are added up, the Rohe score, rotator cuff repair index, when patients have a score beyond 6 or 7 to 9 or above, the percent that are healed shows a dramatic decrease. So those who are less than 7 have a healing rate of about 67% compared to those who heal at a level of 37%. So I'll give you a case example. This is a 49-year-old who's a right-hand dominant laborer with right shoulder pain. He did have a previous rotator cuff tear that was repaired. He was largely asymptomatic in the interim, but presented with worsening pain and function. He sustained an acute abduction injury 3 weeks prior. His basic complaint was significant pain, stiffness, and disability. And what's interesting, his range of motion was actually quite preserved. He had pain with overhead activities. His biceps was non-tender. He did not have lag signs, but he had typical findings on physical exam of painful range of motion. His radiographs were normal. His MRI showed evidence of a previous repair, but what he also had was basically a failure at the level of the enthesis with a minor traumatic event that was difficult to explain his re-tear. The good news is he didn't have significant atrophy, as mentioned, but he did have a failure to heal or a re-tear. Here are his key images. You see the coronal, axial, and sagittal images with a tendon to bone diastasis. So what will you do to prevent failure? There are obvious options such as simple repair. There's the option for augmentation using a collagen implant, dermal grafts, potentially biceps, especially in areas where allografts are not available. There's an entire body of evidence that supports induction at the level of the enthesis, and that may lead to material property improvements and mechanical property improvements. And then there are a number of orthobiologics which have been investigated and we'll discuss briefly. Some of the things to think about that the use of extracellular scaffolds can result in improved material properties and the use of biologics can result in the improvement of structural properties. In the end of the day, what we're trying to do is overcome some of the biologic challenges to improve the enthesis and create mineralized fibrocartilage at the tendon-bone junction. Now, extracellular matrix augmentation has been looked at by a number of individuals, and it's been shown to increase construct mechanics and intrinsic properties and long-term incorporation with lower re-tear rates over time. Animal studies by Jimmy Cook and others have demonstrated that probably the best model, this is a canine model looking at a number of different implants, have demonstrated that the human dermis leads to the best outcomes by MRI, histopathology, and postoperative pain, even when studied in a canine model. Clinically, this is a systematic review that looked at a number of different types of augmentation and extracellular matrices, showing that an allograft extracellular matrix was superior in terms of reducing re-tear rates. We too have looked at the cost effectiveness of extracellular matrix and have shown that from an economical or perspective from healthcare econometrics, that the use of an extracellular matrix is considered cost effective in an ambulatory setting when taken in the context of the cost of revision surgery. The technique for extracellular matrix reconstruction is actually quite straightforward. In this instance, we use a 1 millimeter dermal allograft. The reticular side is facing the rotator cuff. This is an implant that's an all-suture implant that's used that's passed just off the level of the acromion to create a horizontal mattress suture. The objective is to repair the rotator cuff where possible. We use this as an augmentation on top of the rotator cuff and have shown reduced re-tear rates and incorporation into the rotator cuff across the lateral aspect of the tendon and into the bone. And this is essentially what Jimmy Cook investigated in his canine model, but here we know now from a human perspective that we're able to achieve the same level of predictable integration. So the model is introducing the graft from the lateral side, repairing it medially, and then using suture anchors laterally, in this case a self-punching push lock anchor. Post-operatively, the patient is seen with return of normal strength in a relatively early time point. What's important is that we've seen very few failures using extracellular matrix. In this case, as mentioned, a 1 millimeter thick dermis. In the top middle, we see the initial tear in the the bottom center. We're seeing full integration with no evidence of re-tear at 6 months follow-up. Now, there are many areas where allografts are not available, and we have investigated the use of a biceps tendon, which is a low-cost option. So many of us take the biceps at the time of rotator cuff repair. J.T. Tokish has shown that there is tenoside viability in the tendon. And essentially, this is a technique where we take a 2.5 centimeter strip of biceps tendon, place it in a device that essentially will smash it into a 2.5 by 2.5 millimeter, 1 millimeter collagen implant that can be then used to augment rotator cuff repair as an alternative to an allograft dermis. There's plenty of literature that have looked at the biceps tendon for rotator cuff augmentation that have shown that it's safe and efficacious and may work just as well in a setting, for example, that we would commonly use in superior capsular reconstruction. Now, there are a few orthobiologics that are utilized in the setting of rotator cuff repair, namely platelet-rich plasma and bone marrow concentrate. We early on looked at the basic science of PRP with rotator cuff diseased tendon and showed that leukocyte-poor PRP promoted collagen synthesis and decreased catabolic cytokines when we compared it to leukocyte-rich in a culture condition. We also know that PRP is responsible for MSC recruitment, which might be important at the time of rotator cuff repair, and that there are cost-effective ways to stimulate the tuberosity to deliver platelets, sort of a hematogenic response that have showed that in the setting of the so-called crimson duvet, where the tuberosity is denuded, that compared to controls, there may be increased healing rates. So this is sort of a cost-effective way to deliver PRP to the area. But in summary, what has been shown is that PRP in the setting of rotator cuff repair may improve healing rates, especially for small to medium-sized tears, and have been generally demonstrated positive results over time. Now, there are a number of other avenues for orthobiologics, namely the use of connective tissue progenitor cells, no longer necessarily using the term mesenchymal stem cell, but rather cells that produce growth factors that may induce and upregulate the healing environment. One inexpensive way to obtain this would be the use of bursa, which can be obtained in this device, which is attached to the shaver and re-injected. There's a number of basic science studies that have shown that there may be some progenitor capacity and that there's a high concentration of progenitor cells in subacromial bursa that can be injected at the time a rotator cuff repair is performed. Bone marrow concentrate and adipose has also been looked at in the setting of rotator cuff repair by several authors, including Hernagau and others, showing that compared to controls, the healing rates may be significantly improved. We duplicated that study over the last couple of years, where we enrolled 50 patients in each group, half of which underwent rotator cuff repair with bone marrow concentrate added at the end of the case, and half of which underwent rotator cuff repair without bone marrow concentrate. And it was simply injected at the level of the tendon-bone interface. We demonstrated that high-grade changes were seen in those who did not get bone marrow concentrate at the rate of 57%, compared to about 18% when patients received the bone marrow concentrate at the time of rotator cuff repair. Now, there are a number of other mechanisms to improve rotator cuff healing rates, including augmenting the enthesis. A number of individuals have looked at demineralized bone placed at the tendon-bone interface to improve histology, the MRI, and biomechanics. So in conclusion, rotator cuff tears are associated with poor biology and are largely attritional in nature. Rotator cuff tears generally heal with scar in continuity with poor material properties, even if we can improve the structural properties. It has been shown that use of an extracellular matrix in appropriate cases can be supported by the basic science and clinical outcomes, and we have shown that it can be considered cost effective. But there is increasing evidence accumulating in favor of PRP and the use of bone marrow concentrate. Thank you very much.